Okay, so tonight we're going to go over case study 26 and case study 27 from your Harding clinical or critical thinking case studies book, whatever the title is, that one. Wait, I lost what page I was on. There we go. So case study 26 is what we're going to talk about. And then 27, and then we're going to do a little practice with transfusion reactions for some extra fun. So just wanted to speak to the exam grades. I know you guys saw something, a couple of you went in and saw that your overall score was one thing, and then you saw your overall score change, and then we posted the exam grades. There was an error in how the exam was keyed, and so we had to go in and make an adjustment. So if you saw a change in your grade, that's what it was. It was just the number of questions that it scored the exam from was incorrect. It said that we had 87 questions when we only had 82 questions. So that's why there was that discrepancy. So sorry for any confusion. I was going to just triple check everything before I posted your grades and found an error. So yeah, wouldn't want to get to the end of the semester and be like, oh, just kidding. So at least we got it fixed. But yeah, I'm sorry. I know that was confusing and upsetting for some people. And I know the other section actually got their exam grades and then they changed, and I know that can be really frustrating. So we try to prevent those things from happening, but just one slipped by us. So I still don't understand how that number of questions could change. Whatever. The grades that are posted now are correct, and we will not let that particular mistake happen again. Yeah. Okay, so I did want to also say there is one topic that I didn't cover in the stuff that I posted for this week, aplastic anemia. So can anybody tell me about aplastic anemia? What's particular about aplastic anemia? Who did their study guide for anemia this week? This will, hopefully somebody knows what aplastic anemia is.
Can I say?
Aplastic. Yeah.
That is the decreasing the bone marrow function.
Mm-hmm.
And that's, if I'm not mistaken.
Mm-hmm. So what cells are affected?
That is going to be red blood cell and white blood cell.
And what else?
And platelet.
Mm-hmm. So all of them are affected.
Yes.
Very good.
The only things I know about it is this.
Yeah, no, that's great. Brandon, I get you. I saw you. Thank you. So very good. Yes. So everything's affected. So the thing about aplastic anemia is everything's broken, right? Because it's affected there at the source. So all the education, all the complications, all of the precautions that you would take for any individual item, all of the signs and symptoms, those are going to be present in aplastic. So not only are you just anemic, you also don't have an immune system, and you don't have platelets to be able to clot sufficiently. So aplastic anemia is something you're definitely going to need to know about your test. It is for your test. It's covered in your study guide. But just make sure you do a little research on that one, and just pray you never have it, because it's a hot mess, and feel bad for your patients that do, because it's just a lot of things to keep up with when all those different areas are broken, right? Cool. Everybody good with that? We pinky promise that we're going to go look up aplastic anemia and know it for our test. Okay. I'll take that as a yes. All right, moving on. So case study 26, we are going to be talking about anemia, because it seems like a very good thing to talk about. No, it's fine. So we've got our friend GC, a 78-year-old widow, who comes to the outpatient clinic saying that over the past 2 to 3 months, she has felt increasingly tired despite sleeping well at night. Over the past few years, she describes eating less and less meat because of her financial situation and has trouble preparing a meal just for me. So I have how old is he now? My father-in-law, he's 80, I think. But yeah, he says that, so he's actually like a really good cook. He's can make all sorts of stuff, but he lives by himself and he doesn't feel like dirtying a bunch of dishes for, for just him. And he used to cook for, two kids and a wife and all that, but now it's just him and he doesn't see the purpose in making a bunch of food. And he gets tired of eating the same thing over and over again. So he tells us a lot of times he just has like cereal for dinner. We're like, no. I mean, I guess cereal's better than ice cream, but yeah. Anyways, and then finances. Can finances be a thing for the elderly population? So it says she relies on her late husband's Social Security income for all of her expenses. Is that very much? Is she getting a big check? Yeah, so she's on a very limited income. And it's fixed too. She struggles financially to buy medicines for the treatment of hypertension and arthritis. Are medications expensive? Holy cow. And some of them are just obnoxious. Um, Her vital signs are 136/76, respers are 16, pulse is 80. Are we impressed by any of those vital signs? Nah, they're pretty normal, right? So is she pretty stable based on those vital signs? Hmm. She denies any dyspnea or palpitations. If her anemia was bad enough, right, she would have potentially some dyspnea or palpitations, or if it was acute enough, like if it happened quick. But we're not thinking quick anemia for her, right? We're talking months, we're talking years, that kind of thing. Nurse practitioner orders blood work. Her chemistry panel findings are all within normal limits, and her stool fecal occult blood test result is negative. So what is that telling us if her fecal occult blood test is negative? We're going to find out. So why would we do a fecal occult blood test? What are we looking for? Right. So we're trying to rule out what? If there's blood in the stool, that means well, yeah, but where's the blood coming from? Yeah, GI bleeding, right? And you can have slow GI bleeds. So, but she doesn't have a GI bleed. Okay. Other results are shown in the chart. So let's scroll down and see these guys. So again, don't get too caught up in all of these like MCV, MCH, those sorts of things. It's not expected that you memorize all the normals for those. It would be good for you to understand kind of which anemias kind of have, smaller than normal or larger than normal, just to help you differentiate them. But more, make sure you know those WBCs, the hemoglobin hematocrit, and platelet levels, and those kinds of things. And then these other details about indices can help you determine which individual type of anemia your patient has. Okay, so what are the abnormal values here, at least for the top section? Mm-hmm. Correct. And make sure that you know normal hemoglobin, hematocrit, WBCs, and platelets. Okay. Also, her MCV, iron, and ferritin levels are low. So what kind of anemia do we think she has? So we know she's got anemia because the hemoglobin hematocrit levels are low, right? But she also has low iron and ferritin. So what kind of specific anemia do we think? Right. And everybody kind of see, given her history, how iron deficiency anemia is probably what we're looking at. Because remember it said she's like doesn't have much money, she's spending less on meat, and of course iron levels are highest in meat, right? And elderly are at risk for iron deficiency anemia anyway, right? So we talked about which ones were abnormal. Let's go to the next page. Significance, she's anemic. We think she's got iron deficiency anemia. Okay, who all is at risk for iron deficiency anemia? Number 4. Yes, elderly, like our friend here. Who else? Mm-hmm. Yep. Pregnant women, children. Yes, people with restricted diets, like vegetarians, sure. Low income, yep, absolutely. People also who are like chronically ill. Sure, like if you have any, so it'd be contributing factors to the underweight, right? Yeah, chemotherapy would be one for sure. Um, just like poor nutrition overall. Anybody who's got bleeding issues, right? So if you've got, um, yeah, like some kind of chronic GI thing, yeah. So if do you have like peptic ulcers, or if you have actually menstruating females are at risk for iron. Absolutely, bad hemorrhoids, if they're bad enough, you can bleed from them for sure. Yeah, so any kind of blood loss. Um, or dialysis patients. Um, anybody who's at risk for trauma to their red blood cells from things like a mechanical heart valve or something like that. And dialysis kind of falls into that same thing as well. So lots of folks are at risk for this iron deficiency. Okay, so it's a big, broad paintbrush. Signs and symptoms. What do you think signs and symptoms we would see for iron deficiency anemia? Weak, yeah. Pallor, So like the general anemia signs and symptoms. So what are some of those? Yeah, you can get like the clubbing kind of spoon-shaped nails, right? Mm-hmm. They can have some, yeah, headache, sure. They can get the beefy tongue as well. Yep, they can eat stuff that's not food, right, Pika? Isn't that weird? You can also have like some like fuzzy memory, just like difficulty recalling, like you just don't feel like your brain is working very clearly. It's just because of the lack of proper oxygenation, right? Um, yeah, she could have a drop in her O2 level for sure. Um, blah blah blah. Okay, so let's do this one. Number 6. Which question would best help you determine the impact of fatigue on her daily activities of daily living? What do you guys think? Are you upset about feeling more tired? Do you sleep more now than you used to? How far can you walk until you get short of breath? Or have you been able to do what you would like to do? Which one is going to help us get a clearer idea of her activities of daily living? So I would probably argue that D would be a better question to ask. I mean, maybe she doesn't get short of breath when she walks, but it's more like, are you able to do the things that you would like to do? Maybe she doesn't want to walk very far, or maybe she doesn't walk very far. Maybe she just walks around her house and then, you know, to her car, and that's about it. But D would be a better way to get a just a more complete feel as to what's going on with her. Um, everybody with me? Okay. Treatment options. What kind of treatment options do we have for iron deficiency anemia? Yes. So supplements, yeah. Diet, right? Iron-rich foods. Mm-hmm. So make sure you understand what foods contain iron and what are the best sources. What's the issue with iron supplements? Constipation, yep. What else? Mm-hmm. GI upset? Yes. What happens to the stool color? Mm-hmm. Scary stuff, yo. Mm-hmm. When would we give her parenteral iron therapy? It can stain your teeth, you're right. So what does parenteral mean? Yeah, IV, right? So when would we give her iron, like IV iron? What do you think? Any guesses? Sure, she's unconscious, sure. When it's very low, yes, both. Maybe she's not compliant with her oral or can't tolerate it for whatever reason. What else? Mm-hmm. Yeah, if she's got some kind of absorption issues. So for whatever reason, like if she's got a really bad gastritis, we'll talk about gastritis, I think next week, where you just have inflammation of the lining of the stomach, so your absorption is tanked. So that you just can't get enough in your system to maintain levels that you need. Or if she just continues to lose blood, then we're not going to be able to, keep up with the amount that's being lost. Um, so yeah. We kind of already talked about 9, about like side effects of iron, um, that it can cause stomach upset. What about what could she take it with to help promote absorption? Yeah, some kind of vitamin C, right? Like OJ, orange juice, for sure. What should she avoid taking it with? Right, any kind of dairy. And then it's constipating, right? So um, make sure she's aware of that. Okay, let's look at 10. You're evaluating your teaching. You determine that more instruction is needed if GC says. We like to ask these types of questions. Which one is telling you that she did not understand what you said? So which one is wrong? Right, because you don't want to take iron and calcium at the same time, right? Just like you don't want to take your iron with any kind of dairy. Faux show. All right. We'll skip that. Okay, 12. This is a good one. Which is a good source of iron to include in her diet? What do you guys think? We've got some votes for B. We have a vote for C. Okay, so I will tell you that the answer is C because there's not as much iron availability in poultry. Things that contain iron are beans, uh, different dark greens like Swiss chard, spinach, kale, and then you've got like red meats like beef, liver, organ meats, egg yolks. Um, Actually, carrots contain iron and apricots. Who knew? But more red meat rather than like white meat like poultry, pork, and fish. Okay. Um, so yay, kale. Um, Community resources. Okay, so what community resources do you think we could suggest for our friend GC that might be able to help her? Yeah, food pantry for sure. Mm-hmm. My grandmother actually used to get Meals on Wheels, and she loved it. They would bring her, I think, lunch. Sure. Or like some help paying with medications or paying for medications too, if there's some resources available. All right, let's look at 14. Yes, a support group would be good too. Helping her with resources such as like, she doesn't want to eat just by herself. If there's like a community center that she could go to and have meals with other people, that might be a good way to get her like some social interaction, um, and some like positive things around eating too. 14. How would we know that she's getting better? This is one of those types of questions that we like to ask too. What are we going to look at? Yeah, so increase of H&H. What else? Yeah, she can do whatever activities she wants. She doesn't have any pallor. Red blood cell count would be good. Because her main complaints were, getting tired, right? And then she had her abnormal lab values. And we wouldn't want to see a decrease in any of those either. We would want to continue to see stable vital signs. Um, and she can do any activity she wants. And then when we do her just physical exam, that she would feel better, right? All right, let's see. We'll skip that. You can do that if you want. She returns to the clinic in 3 months. She's saying she feels a bit less tired, although her blood work shows some improvement, anemia is still present. GC and you discuss ways to promote better eating. She tells you she did not follow up on any of your suggestions about seeking community resources. Does that happen? Bless it. Um, oh goodness. Yeah. You didn't follow up on any of them? None? Okay. She now agrees to speak with the social worker and to explore some available resources. So that's some real life nursing right there. Didn't follow on any? None? Not even one? Okay. Okay, we're going to do case study number 27. Uh, of note, all of these case studies are under gas exchange. Why are they under gas exchange? Why would case studies of anemia be under that topic? Things to think about. Because you're not getting adequate oxygenation to tissues, right? Right. That's right. because hemoglobin's job is to carry oxygen. If you ain't got them, they ain't carrying it. Or if your cells are misshaped, or they're getting chewed up, all the different types of anemia. All right, this is a good one. So VM is a 29-year-old African American married man who has sickle cell disease, marked by frequent episodes of severe pain. Because remember, sickle cell is characterized by these episodes of severe pain. His anemia has been managed with multiple transfusions. 6 months ago, he started showing signs of chronic renal failure. His regular medications are acetaminophen, hydroxyurea, and folic acid. In the hematology clinic this morning, his hemoglobin measured 6.7. He received 2 units of packed red blood cells over 3 hours and then went home. He developed dyspnea and shortness of breath. About 1 hour later, his wife called 911. The emergency medical system crew started O2 at 8 liters per nasal cannula and transported VM to the emergency department. Anybody see any red flags from our little story there? Yes, that is a problem. Can we give 8 liters per nasal cannula? No, that's too much. Please don't do that ever. If you're ever in my sim class, I'll fire you if you try to put 8 liters on a nasal cannula. Not really fire you, but I will shake my head. Renal failure. Yeah, so what's the problem with the renal failure? Yes, potentially, right? How many units of packed red blood cells did he get? 2. Anybody have any idea how much volume there might be in that? It's a lot. So I think it's like, I'm trying to remember from my experience. I think it's like 350. They're different. They're different volumes, and they say on the bag. But he got some extra volume, regardless of the exact number. You got this guy with some chronic renal failure happening. He got the 2 units. He started feeling shortness of breath. So it kind of walks like some fluid volume overload and kind of talks like some fluid volume overload, right? Okay, so our friend has got dyspnea, shortness of breath an hour after this transfusion. Um, the EMS crew got him on some messed up nasal cannula. Sickle cell disease, we're not going to talk about that. Let's do number 2. True or false? Only African Americans get sickle cell disease. False. That's right. The highest prevalence is in African descent, but people from Spanish-speaking regions like South and Central America, Saudi Arabia, India, Mediterranean countries such as Turkey, Greece, Italy, all have, all can have sickle cell disease. Number 2, there is currently no cure for sickle cell disease. True or false? That is true. True, no cure. Those with sickle cell disease should not receive childhood vaccinations. True or false? False, right? Higher risk of infection. So they need their vaccines. And remember, infections can trigger these sickle cell crises. Number 4, sickle cell disease cannot be diagnosed before an infant is 3 to 4 months old. True or false? That's false, right? Newborns can get screened. 5, an ophthalmologist should perform an eye examination every 1 to 2 years. True or false? That's true. They can have some vision issues, right? Because if you think of the little tiny capillaries getting blocked up, that can affect your eyesight too. And then 6, those with sickle cell disease should fly only in airplanes with pressurized cabins. So you got to think about oxygenation, right? You don't want to decrease the level of O2 in the air with people with sickle cell disease because that can trigger sickling, okay? So that is true. Okay, we're going to skip number 3. So number 4, his hemoglobin is 6.7. Is that high, low, or normal? That's really low, right? So why do folks with sickle cell have anemia? They got a couple different reasons. It is inherited, yeah, but yes, the cells themselves are abnormal, yeah, and they get destroyed, right. So the cells themselves are fragile and they can just get damaged quicker and they rupture more easily. And they also die after about 20 days instead of 120 days. So they just don't have a very long lifespan. And then what happens, how are the kidneys wrapped up in this whole issue of sickle cell disease? What happens to your kidneys when you have these episodes? Not really stenosis. Yeah, they get clogged up. So if you're not filtering stuff through your kidneys correctly, what is um, the substance that's made in the kidneys that has to do with your red blood cells? Extra points if you spell it right. How about erythropoietin? There you go. So if you're not producing that like you should, because your kidneys are getting plugged up because you've got these funky shaped cells, then you're going to compound your anemias, right? So got a couple things going on. Okay. Number 5, it's difficult to type and cross them because they can get a bunch of antibodies. When you get a lots of transfusions, it just becomes more and more difficult to match because you get all these potential reactions. And so it just takes a while to make sure that the blood that these patients are getting doesn't have any of those things that are going to get triggered. Okay. We could skip number 6. Okay. So continuing on, VM arrives to the ER. You do a quick assessment. He's got a systolic murmur, crackles in the bases bilaterally. He's got a blood pressure of 176 over 102, pulse 94, respir's 28. He's afebrile, O2 sats 78 because that 8-liter nasal cannula is not helping him. Peripheral pulses are equal and 3 plus. Alert oriented, tell you he's nauseated, belly is non-tender, hypoactive bowel sounds times 4. You start an IV, you get an ABG, draw some blood, and you get a CBC and a BMP. So the ED resident asks him whether he's in pain and whether he needs pain medication. VM answers no to both questions. Why did the ED resident ask these questions? What is he trying to figure out? Right, so what would that mean? Yes, which is what? What is he trying to find out? If he's having a what? Mm-mm. Vaso-occlusive crisis is right, yes, but what is that? What kind of crisis? No. You guys are getting too detailed. Pull back. Not hypertension. No. Yes, what is that? What does he have? I feel like I'm asking the wrong question. Yes, sickle cell disease. He's trying to figure out if he's got a sickle cell crisis. Yes. Because if he's having a sickle cell crisis, if he's having this vaso-occlusive crisis, if he's having this exacerbation of a sickle cell disease, then he would have joint pain, right? Because like the hallmark of these sickling episodes is pain, significant pain, right? Like I need IV narcotics pain. So is VM having an exacerbation of a sickle cell disease? No, he's not, because he would be in pain if he was. Make sense? Okay, number 8. He's got his ABGs on his 8 liters by simple face mask. The PaO2 is 74. Is he being adequately oxygenated? Nope, not quite. Number 9. Are your assessment findings consistent with fluid overload or deficit? What findings led you to your conclusion? Here, let's go back up so you can look at those. So what of these show us fluid volume load? Ignore the highlighting. I don't know why it's highlighting. Stop it. Yep, the BP, the edema, 3+, yep, crackles. What else? Yep. What about the grade 3 systolic murmur? Yeah. That's not normal. Okay, very good. Let's keep going. We're skipping that. So you see the BUN and creatinine? Are those normal? Anybody know? Hi, yeah. So it's not a sickle cell crisis. Remember we were looking at the beginning where he got those 2 units. He's got some chronic renal disease. And so we talked about, and he got those units over 3 hours, which we usually give 1 unit over 3 hours. We're going to talk about this in just a second, but he just basically got slammed with too much fluid. So yeah, it's more fluid volume overload than it is sickle cell crisis. Okay, so this is kind of a tricky one because we get to talk about sickle cell disease, but it's not actually an exacerbation of sickle cell disease. Okay, so yeah, BUN and creatinine are bumped. Hemoglobin, hematocrit are down, but we already knew that. Okay, so he's complaining of being short of breath. Do we believe that the low hemoglobin level is responsible for his complaints? So the thing to keep in mind is people who have chronic anemia, are they going to be very symptomatic of lower hemoglobin levels? So remember he was 6.7 or something before, now he's 7.8. So he's actually improved from where he was. So they're not going to have as much symptoms of their anemia because their body learns to figure it out. Okay, so his shortness of breath, do you think it's more related to a hemoglobin level, or what else could be causing that shortness of breath that we've been talking about kind of all along? Yeah, so less anemia, more fluid volume overload. Can you get shortness of breath from both? Yes. But this is like the reason I love this case study is it forces you to critically think and kind of put it into context, and it kind of connects anemia to uh, chronic renal failure to heart failure. It kind of starts weaving all these things together. You guys see how these are kind of dancing around each other? And so with this particular patient, he's got 3 potential issues, right, that could be causing, or at least 2 potential issues that could be causing this. And so you kind of have to play detective, right? And for him, it seems like maybe he just got too much volume. Could it be his hemoglobin level? Yeah, but it's probably more that he just got so much volume. So if we think he's got fluid volume overload, what do we need to do to treat him? What do we give? Yeah, yeah. Let's give our friend some Lasix. And so how would we know that our Lasix is working? What kind of findings are we going to have? He'd lose some weight. He'd have some increased urine output, decreased edema. Yeah, so what else? What is his main complaint? Yeah, he can breathe. What else? What was the other thing that he had that was ridiculous? Where he had an OT sat of like what? Do you remember? On his 8 liters of cannula, which was dumb. Yeah, we want that OT sat to go up, right? And a lower heart rate. Yep. Cool. Um, so he goes to the bathroom. His dyspnea is better. He shakes the resident's hand and thanks him for asking if he was in pain. He says, one of my biggest fears is that I'll come here in crisis and the doctor won't treat my pain aggressively enough. I don't want to be labeled as a drug seeker or an emergency room abuser. Is this a whole thing for our clients who have sickle cell disease? Oh, yes. Uh, and I have witnessed it because they do frequently come into the ER with these vaso-occlusive crises, and you get people who are like, oh, they just want drugs. But really, no, they've got these blockages that are happening in their, their vasculature that causes the severe pain. And if we can manage their pain and get them oxygenated and get them some fluids, we can reverse this whole process. And so it can be really problematic. Get these people the help that they need. Yeah. Anyways, um, something to keep in mind if you run across this in your practice, that you have to aggressively treat and manage pain for your sickle cell patients. Get them oxygenated, get them fluids, so you can prevent this damage that happens all over their bodies. And then education. So just FYI, units of blood usually go over about 3 hours each, not 2 units in 3 hours. Especially somebody who's got some chronic renal failure. We just slammed his poor body and his less than functioning well kidneys with just too much. And so he wound up in fluid volume overload. So whenever we discharge our friend, we just want to be like, hey, next time you get a transfusion, don't let them give it to you that fast, because that's just not good for you. Or you can give, a lot of times with folks that have got either heart failure or renal issues, they'll give like a diuretic after the first unit um, to help prevent this problem. Okay, so just some education to your patient to equip them and empower them so they don't wind up in this situation, because it shouldn't have happened. This was just an error on the part of whoever it was that gave them these units. Okay, so VM is discharged from the ED after being observed for 6 hours. He's instructed to follow up with his primary care about the episode and discuss with the hematology clinic staff longer transfusion times for any future transfusions. All right. So we are out of time. I'm gonna have to post the practice for the blood transfusion stuff just as an announcement. So I'll get that posted with the answers. So make sure to work on those. And other than that, anybody have any questions?
I had a quick question real quick.
Sure.
Let's see, where are my notes? There was one I was reading about for sickle cell that was saying that if you did like a stem cell transplant early on, it can be like more reversible.
Interesting.
I didn't know if that was true or not.
I mean, sure, if that's what you read.
Okay.
I think I'm not aware of that. That does not mean that that's not a thing. For the most part, it is something that just is not curable. It has to be managed. And I'm sure they're coming up with stuff all the time. So that's entirely possible, but that's not anything that you're expected to know for your test.
Okay, awesome. Thank you.
You're welcome. All right. Well, y'all have a great evening. Thank you so much for coming. Thank you for participating. Hopefully this was educationally valuable. And otherwise, take care of yourselves. And I will talk to you next week.